So,
Yes.
is this working okay? Can you hear all right? Okay. So I think we might start by thanking the survivors of the conference for being here. And if I see any of you run out, I'll assume it's planes and trains and not the session. Yesterday I was at a session where the questions were really fantastic. So we're going to do our best to ensure that you're all made to work as well as the speakers. We're going to address two questions. The first question is, how should priorities be determined? Or put another way, what is it we want to do, and do we have the evidence to prove it? My own view is that we actually do have the answers and we do know what we want. And I think when we're talking about a public health framework, we're talking about something relatively simple, even though the context is going to vary from country to country. So what we're talking about is information, early diagnosis, effective treatment, quality care, preventative health, and investment in research. Those seem to me to be the main things we're talking about. I think the other question that we might look at in terms of how should priorities be determined is whether, having determined them, we actually communicate them well to government and the wider community. And if I can speak about Australia for just a second, I think the biggest challenge we have in Australia is not the lack of intellectual capital and knowing what we want to do. It's actually persuading government and the community that they understand our story and are prepared to act. So the second question that we're going to address after that one is what has been learned in Europe in implementing plans and what has been achieved. So the second one is all about outcomes. So, keeping to my promise, we'll get on with the two presenters, and what we're going to do is to have two speakers on each question, use up half the time on each question, so there should be 15 to 20 minutes of questions that you'll have time to answer. And if you don't ask questions, then we'll preach a bit more at you. So take your choice. So the first speaker is going to be Maurice O'Connell, who I think will be known to many of you. Maurice has been the Chief Executive of the Alzheimer Society Ireland since 1999 and has been on the board of Alzheimer Europe since 2000. He served as Honorary Secretary 2002 to 2004 and as Chair 2004-2010 of Alzheimer Europe. And Maurice is going to be our first speaker on how should priorities be determined. Over to you, Maurice.
Can you hear me? Yeah, good. Thanks very much for the opportunity. And I suppose one of the things about where we are in Ireland is that we don't have a strategy at this moment in time. So we are at the stage where I suppose we've done a lot of political advocacy around making sure that our new government was able to commit to a plan regarding dementia. And we managed in this new programme for government to get a statement that dementia will become a healthcare priority, and by 2013 we will have a strategy. And so we're, the first hurdle has been crossed over, if you like. I think the most important thing after that then is, well, what would we like to see in a plan? We did have a plan back in 1999 written by Professor Eamon O'Shea, and it was a very good plan, but it sat on a shelf. So we want to make sure that if this plan is going to work, it needs to have some serious element of implementation. And I suppose what we want to see, first of all, is a whole program around early diagnosis. We want appropriate assessment around that, And we would like that earlier diagnosis to focus very much on the importance of the personal decision-making of the person living with dementia. We would also want that whatever the program was to make sure that we were listening to the voice of the person with dementia and their family members. I think the other challenge around earlier diagnosis that we'd like to see is to make sure that we develop a clear social, clinical and personal pathway in regard to their care and appropriate, I suppose, interventions along the pathway of dementia. I think the second most important thing that we would like to see in terms of a plan which will underpin maybe this plan would be a challenge to the system, to the healthcare system, that in a real sense to make sure that rather than respond to the services provided, that we begin to turn that on its head and look at what the needs of the person with dementia would be. And then make sure that we have a joined-up kind of service that would link primary, acute, and long-term care in order for it to be consistent and have a continuum of responses. We'd also like to see in that continuum a shift towards a rehabilitative model of care where we want people to be I suppose, retain what they have, to renew the elements of their skills and to be able to have some realization of what they can become. I think the other element of the plan would be for us is to renew or review long-term care, to look at new models, to somehow find putting the person back into the center of our long-term care responses and to focus on the needs of the person and making, I suppose, places of care friendly places. And I'd like to make sure that what we want to plan for the future is friendly, ordinary places where people would want to go. I think the other element is awareness and education, which underpins a lot of the first 2 points in terms of making sure that various groups within our society are challenged in regard to maybe general public awareness around the fight against stigmatization, making dementia a friendly focus, and also then moving on to making sure that the family carers are given the kind of resources that will enable them to deal with some of the burden and challenges they have, but also to give them the educative tools and information to be able to make decisions. I think this plan needs to be very simple. It shouldn't be complicated, and it should be doable. And one of the elements that I'd like us to explore would to make sure that dementia straddles more than just our health system, that it's important to consider housing policy, social welfare, transport, and planning in order to make sure that people with dementia live well enough in our communities. The challenge, I believe, will be to create a more equitable availability of our services and supports, because it depends, it's a bit of a postal lottery at the moment. It depends on where you live in regard to the level of your service. And I suppose as I get older, I want to make sure that people know what I want. So it's very important that any decision-making around the person is that you involve the person and make sure that their voice is heard. Another element is obviously three other points. One is that I'd like to make sure that in this strategy, we promote well-being in dementia, and that I would like this plan to find a way to invest in prevention and education, in what is good for our heads, making sure that we deal with the whole person. And lastly, I think it's really important that we focus on a real investment in psychosocial research, so that we're not just reliant on a pharmacological response, but that we're looking at the real needs of people in their community and in their relationship. And I think this plan needs to be short, and it needs consistent evaluation in order for us to learn.
Thank you, Maurice. I was very rude in opening the session by not explaining who I actually am and where I come from. I'm afraid it's the other side of the world, which may be some excuse, Australia. I've been CEO of Alzheimer's Australia for nearly 12 years, and in terms of the job I did before that was most relevant to what I do now, I headed up aged care in Australia and disabilities and housing for about 8 years, from 85 through to 93. So that's my background. So sorry about that. We move on to our next speaker, who's Jeff Huggins, whose idea of a joke was to tell me that he was going to speak for 25 minutes, and I'm assured that that, in fact, was a joke. So we'll see. Jeff is the Deputy Director of Healthcare Policy and Strategy Directorate and Head of Mental Health Division in the Scottish Government. Jeff has policy responsibility for mental health services, mental health improvement and mental health law. Over to you, Jeff.
Thanks very much. I think you've actually read out my old biography. My new biography is actually in the packs, so you can actually see what I'm doing now, which is also about social care. And I think, but a key component of that was that I'm here from the Scottish Government, and many of your speakers over the last 2 days, very few of them have come from government. Very few of them are part of government, and there's been a sense which I've had, which is that there's an objective which is to lobby government and to encourage government to step forward. We would like to collaborate with you. Our objective in Scotland is to collaborate with the Alzheimer's movement across Europe, but also with people with dementia and with their carers. We're not that keen on being lobbied, but we do want to work with you and we do want to engage with you, and those two things are quite different. My perspective is that health, social care and social policy for the next 20 years are going to be largely structured around issues to do with how we tackle and how we manage and how we respond to dementia. I think the change that we're going to see in social care within my country and in many of your countries is going to be about how we adopt and change to be able to provide an appropriate response to the challenge that dementia gives us. But I think in terms of knowledge and understanding of that, very few people understand that still. You're among those people, but there is a large majority of people who have yet to wake up to the challenge that faces them over the next 20 years. I'm going to approach the topic here, which is about priorities, by saying a wee bit about how we got to where we are in Scotland now in 2011. In 2007, the Scottish Government established dementia as a national priority, and at that time we considered whether we would produce a strategy, and we decided that we wouldn't produce a strategy. We identified that there were 4 or 5 things that we knew would bring benefit, and we decided that instead of spending some time, a year or 18 months, going through the process of writing a document and consulting, we would get on with some action. So we set ourselves a target which was to increase diagnosis of dementia. We said that we would expect to have 61% of all people with dementia registered with their general practitioner using prevalence figures. We put in place some work on post-diagnostic support and funded 3 pilots to do that in Scotland. We began to develop better materials for the post-diagnostic period. And we also created a national dementia forum involving the voluntary sector, people with dementia, people who are their carers, but also the statutory agencies, which was chaired by our Minister for Health, and which became a place where we could talk about what was going on in terms of the development of work on dementia and what the challenges were. And our objective in doing all of these things was to begin by creating some movement and begin in the early part of 2007 by actually beginning to address the challenges that we already knew were there in advance of writing a strategy. In June 2009, we decided that, based on the work that we'd been doing and the need to give some of that work additional structure, that we would produce a strategy, and we went into the traditional process of consultation and engagement, but we brought some additional knowledge that we had from the work that we'd already done at that stage into the process. And I think we also brought an additional element of engagement and an additional element of trust, in that we were doing this work on the basis of having already invested time and effort right across the health and social care system in working on dementia. And we identified a number of key challenges. We used an open consultative process. We had a range of both public meetings but also targeted meetings with particular interest groups to bring out the issues that were significant to people. We ran the work probably over around 9 months and published the completed strategy, having published a draft strategy in June 2010. And I've got 2 copies of it here, and I'm happy that the person who asks the best question can have one of the copies. It is available for under license for you to deliver in your own countries, should you decide to do so. Within that, we identified 2 key change processes. One was around improved post-diagnostic support. By the time we were into 2010, we had already made significant progress on our better diagnosis target. And I can report that in March 2011, we achieved and exceeded our target. So we're currently sitting at 61% of diagnosis being registered within Scotland. So we identified post-diagnostic support as the next big challenge. But also we identified the care and treatment of people within general hospital settings, in that while we quite often think of dementia as it presents as dementia in a specialist setting or in a primary care setting, people with dementia appear everywhere across our healthcare system. And the work that we were beginning to see in 2008 and 2009 was telling us that for the older people within general hospital settings, significant numbers of those people had dementia. And when they had dementia, they had poorer health outcomes, were more likely to become a delayed discharge, and were more likely to spend longer periods of time within hospital. So they were having the worst outcomes for people in hospital. So we identified that as a key change area. On the back of those 2 areas, we established 7 or 8 tangible, brief commitments. When we began the process of writing the strategy, we said at the outset that it would be a 3-year strategy. One of the objectives with that is that everybody is still in the same job at the time when you have to deliver the strategy. So people can't say it was somebody else's idea, or the people who have the idea can't move on to something better or something different. So I expect I'll still be doing the job which I'm currently doing at the time when this strategy has to be delivered. And the same is the case for the minister involved, for the cabinet secretary who's involved now. In terms of the strategy itself, we identified the need to work on standards and quality of care, looking to develop standards that applied right across the system, not for particular locations or professions. So a standard that would apply to somebody with dementia, whether they're in hospital, in primary care, in the community, and whether it's a nurse or a social worker or a care worker working with them. And we also identified work on workforce, and we published 2 documents on each of those items within 12 months, and we're now into the implementation stage on that. We also focused on information and knowledge to actually begin to get an understanding of what's going on within our system, with the objective of being able to then benchmark from area to area within Scotland and to benchmark ourselves against other countries so that we can know how we're performing in responding to dementia relative to other countries that also collect data. And data is immensely powerful in this area in terms of producing change. And in addition to that, we built in performance management. Twice a year I go out and I visit each of the 14 health boards in Scotland, and I hold them to account for what they are delivering in respect of their components of the dementia strategy. And we have an across-the-table discussion, the outcome of which is then published, and annually they're also subject to review by our Deputy First Minister in a public forum again. So performance management in terms of holding people to account is a key component of the process. We're halfway through the 3-year strategy now. In the spring, we're going to begin the engagement process to produce our second strategy, which will be published before the summer of 2013. And again, what it will do is build on and learn from what we've learned along the way, because we would now write commitments and objectives that we wouldn't have written 18 months ago when we produced this strategy, simply on the basis of what we now know. And that sort of fast cycle learning process, I think, needs to be key to what we're doing in this area. We have a new minister, a new cabinet secretary, the Deputy First Minister, the second most important person in our government, and she has identified dementia and the care of older people as her #1 personal commitment for the 5 years of this government. She made her first major speech after the election at the Alzheimer Scotland Conference, and she set out her stall in terms of what she would intend to achieve over the next 5 years. Do I have time for just a couple of quick reflections? I'm desperate not to spend 25 minutes now that I've been challenged on that. I think there's a few quick thoughts, and these are more how to do things rather than what to do, and I think the hows are really important here. First of all, you need to build trust and engagement across the sector. The purpose of having a strategy is to get a consensus about what you're trying to achieve. I think there needs to be a bias towards action. This is not, any strategy shouldn't be a rhetorical document. It shouldn't be a theoretical document. It should be a document which has got clear commitments and objectives that you then go on and deliver and be prepared to be judged on. Performance management's part of that, but also engaging and working with people with dementia. They need to be part of the story. And people with dementia sit on our implementation group, which tracks progress against the strategy. They were involved in the formation of it, they're involved in the performance management of it, and they also support the change process at local level. Be opportunistic. Things will come along which give you the chance to plug dementia into somebody else's work. Take those chances. But also collaborate across the system. Don't see people like me who are in government as the enemy or as adversaries. If you can help us help you, it will generally work better. But finally, and I guess this is probably the key point, whenever you produce your strategy, at the end of the day, all you have is a document. And ultimately, what we are about in this game is change. So you need to have your hands on the process of performance management, of improvement, and of change, and you need to develop that momentum.
Thank you, Jeff. I think that's fascinating in terms of sustainability, because it's one thing to have a plan, it's another thing to get it going, and then it's another thing to actually get it continued. And I think what you're doing is a fantastic model. So, you've got at least 15 minutes, so who would like to ask the first question, please? This isn't an arranged question.
I do not compete for the best question. It's just that I wanted to know, planning this plan or really thinking how it should be, was it necessary in your country to change the existing structures for that? Structures of the national healthcare system, structures of how the cash flow or the money flow would be? Because if I would consider such a thing for Germany, if we would like to have such a similar thing, there must be so many changes that I can't imagine that we can achieve it in 3 years, as you said.
I don't think we really did change many structures. Healthcare systems and social care systems are incredibly complex things. What we tend to do is that we identify the outcome that we want to achieve, and then we find a way in which we can manipulate or use the existing structure to give us that outcome. So if you think one of the examples which I'd identified there was earlier diagnosis, in the United Kingdom, general practitioners are required to keep a register of people in their practice who have a diagnosis of dementia. And so our objective within that was to increase the number of people on that register. They're already being paid to hold the register, and then they're required to do physical health checks, which gives us a check about change over time as well. But what we then did was that we then engaged with secondary care colleagues, specialist colleagues. We mobilised in some places the Scottish Dementia Working Group members to talk to primary care doctors as well about the value of diagnosis. And so we worked within the system using some levers that were there already. And it might be that if we hadn't had that particular element of the GP contract, we might have done something else. And I guess that's one of the elements of being opportunistic and working with the system rather than spending large periods of time battling against the system.
Okay, next question now.
Hi, I study national and subnational plans, listening to American show tunes. It somehow gets me through. But they don't nearly have the burr that the wonderful gentleman from Scotland has, so maybe that's the easier way to learn about the Scottish plan. So here's my question. We're in an era with the most complex science about Alzheimer's disease that we've ever had. And scientific opinion is starting to congeal, for lack of a better word, around modifiable risk factors for Alzheimer's and dementia, another area of classic public health. As concerned as we are about people with Alzheimer's disease and their carers and systems of care as they are today, I'd rather, if there is a way, apply resources. This was a question about what values we apply to these plans. I'd rather see applying some resources to cutting it off at the pass, working on risk reduction, particularly in a climate where now with the UN Summit on non-communicable diseases and shared risk factors with all these other horrible killers or horrible chronic illnesses that are costing health systems enormous amounts of money, how do we, from a values point of view or a priorities point of view, see public health start to apply some resources to risk reduction?
Who would like to?
I could offer something. We addressed that on the basis of work that previously had been done around risk factors. And in terms of the particular issues around exercise, diet and healthy lifestyle, we identified that what was largely being recommended was things that were being recommended for the general population anyway. And so on that basis, we didn't make it a specific part of the dementia strategy. We already have a public health function within Scotland, and we decided that that would carry that weight of taking that forward.
So the follow-up question is, are brain health messages part of that campaign?
They are, and Alzheimer Scotland was funded by the Scottish Government over a period of time to provide information about the linkage between healthy lifestyle and Alzheimer's disease. There's a broader question there, which is the question about whether the fact that this is linked to Alzheimer's disease is actually a motivator for people to engage in healthier behaviour. And the evidence is that it's probably, the indications to us are that it's probably not, in that the reasons why people do or don't engage in healthy lifestyle are likely to be more internally focused rather than risk focused in future life. So people may know this cognitively, but it doesn't become a motivator for change. So it's a challenge.
I'd have to say, in the Australian environment, it's immensely frustrating that dementia gets high priority in everything to do with aged care, but not to do with health. And I regard the prevention risk reduction issue as a really good one for us to open up a more serious debate with the health area of our department, which, whenever it gets a chance, flicks anything to do with dementia, whether it's primary care, hospitals, or risk reduction, across to the aged care division. So I would take a slightly different view from Jeff, I think, and in our context, we're arguing very strongly that any prevention program should make a link between the physical health and the brain health, and that when they're promoting heart, diabetes, obesity, anti-smoking, anti-alcohol excess, then dementia should be mentioned as one of the things that may benefit the individual in terms of some risk factor protection without going overboard about it. So for us, that's quite an important strategy. Another question? Come on, don't disappoint me. Peter.
Peter Ashley. I start by an apology. It's not a question so much as a statement, an apology that we don't have the same degree of representation from government from England that we seem to have from Scotland and Ireland. So it's an apology in that sense. I'm not a believer, as it happens, in devolution. But that said, I have to acknowledge that our friends in Scotland have performed very much better, although later than we did, in the area of dementia. They have policies which they are executing in a clear and well-defined manner, and to the extent that Ireland are a little bit further behind, perhaps, they are doing likewise. The problem with England is that we have moved into it rather rapidly, done an awful lot of things, but we tend to get confused with our political masters, and we mess about too much, so that the policies become cloudy, diluted, and not supported in the way they should by the people that matter. And I talk about myself and carers and others like me who are the recipients of that policy. So I want to simply clarify for those of you who don't know the way we operate in the United Kingdom and Ireland, just what is happening, compliment our Scottish friends, compliment our Irish friends, and say, albeit remotely, we are trying to do something in England, but I wish there was some politician here to actually stand up and be counted. Thank you.
Thank you, Peter.
Yes, maybe another comment on prevention, and maybe it's just because we're two from government, so I must admit that I share your view regarding prevention. I would add one comment, which is we know so little about this disease of Alzheimer and dementia that maybe that's one of the reasons why it is so difficult to promote real prevention actions. But on the opposite, we have scientific evidence of the link between smoking and cancer. And yet, I'm sure that if we asked in the room, a number of you are still smoking, while at the same time they know that this increases dramatically the risk of having a cancer in their life. So, speaking from a public policy point of view, first, if you want to launch prevention campaigns, and you need to have real scientific evidence, and to my knowledge, we do not have so much evidence regarding dementia. We have it on heart attacks, strokes, cancers, but not so much on dementia. So we can just say that, of course, if you make prevention for heart attacks or strokes, that certainly it will work also in some way, maybe for dementia, but you cannot go further than that. And second, even for other diseases, apparently it's not so efficient. So I'm not sure that we should spend a lot of money and a lot of public energy in prevention as long as we are in this situation today. And on the contrary, now we have scientific publications, and Armel Desplanques is here from the National Health Authority in Paris. It has been proved, scientifically proved, that the prescription of neuroleptics and psychotropes is detrimental for people with dementia. And that's the reason why we have in France, and you also have in the UK, by the way, a real public policy in order to reduce significantly the prescription of psychotropes and neuroleptics for people with dementia. But you must keep in mind that when you are in government, you can take action only when it's based on real scientific evidence And I'm not sure that we have that level of scientific certainty regarding the prevention of dementia. And of course, we would all like to know more about dementia, about the prevention of dementia, but maybe that's for the future.
Good. There's something we disagree on. That's positive. Next question. Please do.
Nie wiem, czy ja dobrze wejdę w temat, który jest teraz mówiony, ale jednak chciałbym powiedzieć o kilku sprawach w Polsce. Mówimy o tym, że sprawa demencji i sprawa profilaktyki powinna być priorytetem w służbie zdrowia, wśród tych, którzy decydują o kształcie służby zdrowia. Jeśli chodzi o moje doświadczenia z Warszawy i okolic Warszawy, a na pewno też z innych miast, mamy taką sytuację, że z jednej strony zupełnie brak świadomości społecznej, jakim problemem jest demencja. W związku z tym i wszystkie plany choroby Alzheimera są odkładane na później, a z drugiej strony liczba chorych jest ogromna i etap, w którym chory się znajduje, poza pierwszym okresem, kiedy nie jest rozpoznana choroba, drugim okresem, kiedy jest pod opieką rodziny, następuje trzeci okres, kiedy ten chory siłą rzeczy, brakiem możliwości w rodzinie, jest oddawany na zewnątrz. I tutaj mamy ogromny problem z mojego doświadczenia. Wokół dużych miast polskich, a w Warszawie też, powstają sporadycznie, powstają nowe domy opieki. One są budowane w większości chyba jako biznes, ponieważ chorych nie tylko z chorobą Alzheimera przybywa. Warunki terapii z punktu widzenia chorego w tych domach są moim zdaniem najgorsze. Co zrobić, aby w planach, które będą budowane, zwrócić na to uwagę? Bo słyszeliśmy dzisiaj, przynajmniej z polskich tu doświadczeń, że jest kilka wspaniale pracujących domów ze specjalnością leczenia chorych na Alzheimera. Ale przecież ci chorzy znajdują się, ponieważ jest ich dużo, będzie coraz więcej, znajdują się w innych domach. I to jest na przykład w grupie osób w danym domu, tam 30 osób, jest 4 czy 5 osoby z chorobą Alzheimera. Tam nie ma żadnej terapii. Moim zdaniem to jest najgorszy moment, najgorsze warunki, jakie mają osoby chore, które są już poza domem. Przepraszam, że tak trochę chaotycznie mówię, ale to na sercu mi leży, bo ja jestem nie chory, ale jestem opiekunem tak zwanym.
Dziękuję. Ja tylko dopowiem, ponieważ pan Witold jest członkiem naszego stowarzyszenia i zna sytuację, ale jednak ją w jakiś sposób zawęża. Nasze stowarzyszenie ma orientację, jak to rzeczywiście wygląda w skali. Jest rzeczywiście bardzo źle. Jeśli mówimy na przykład o domach dziennego pobytu, nie wiem, czy państwo uwierzycie, Warszawa ma blisko 2 miliony ludzi, mieszkańców, ponad 30 000 chorych na demencję i ma jeden dom dziennego pobytu dla 12 osób. 12. Czyli tak jakby w ogóle nic nie miała, ponieważ odległości między dzielnicami są tak ogromne, że gdyby nawet tam było miejsce, którego nie może być, to przewiezienie chorego po prostu powodowałoby to, że ten opiekun by nigdy w życiu nie dotarł do pracy. Jeżeli chodzi o domy stałego pobytu, sytuacja jest nie lepsza. W Warszawie powstał pierwszy dom specjalistyczny dla chorych z demencją, a chorzy trafiają do państwowych domów pomocy społecznej, gdzie są ludzie z chorobami somatycznymi wieku starszego, gdzie nie ma, tak jak pan Witek powiedział, nie ma terapii specjalizowanej, kierowanej do tych chorych i jest ogromna rzesza, w tej chwili ogromna liczba domów dziennego pobytu, stałego pobytu prywatnych, które rzeczywiście są rodzajem biznesu, choć trzeba powiedzieć uczciwie, że niektóre z tych domów rzeczywiście spełniają wszelkie standardy, zarówno poziomu tego, w jakim żyją chorzy, jak i standardy odnośnie terapii, ale to są oczywiście pojedyncze bardzo przypadki. Dziękuję.
Yes, maybe just an example of what we have decided to do in France, to come back to your question regarding the nursing homes. In fact, the topic that we wanted to address in France was the following. It was how to deal with people with behavioral troubles in nursing homes. Because we faced a situation in France where we have quite a lot of nursing homes, but some of them, or most of them, will not accept persons with dementia. And when you ask them the reason why they do not want to take persons with dementia, the reason is that they might have or they already have behavioral troubles. So for us, the central question is how to help the management of the nursing homes in dealing with these behavioral troubles. And we have had a lot of expert groups, including experts coming from abroad. And we have finally designed a specific solution, which is a day solution, a specific unit with an adapted architecture and occupational therapists who come in the nursing home and who deal with these patients with behavioral troubles. And the experience has shown that, of course, there is a significant decrease in the behavioral troubles. Then at night when these persons go back in their rooms, then they are quiet and they sleep at night. And last but not least, the prescription of neuroleptics drops also significantly. So there are solutions. Basically, the solution is an adapted architecture and professionals who know how to deal with these people. So it's feasible. But it's true that it took 2 years in France just to imagine this solution. And there were large debates around this topic. And then it took another year, and it's not the end of the story, to convince the local management of the nursing homes of the adequacy of this solution. Because even when you have large debates with high-level experts, you are very far from the local nursing homes. So first you draft or you design your solution, and then you have to sell them, to market them towards the nursing homes themselves. But we have some studies which are available on our website. Maybe you could have a look at them, and definitely we know that this is working. The difficulty is the implementation.
I think we'll have to move to the second question now, but if I could just make one observation. A huge mistake in Australia over 40 years has been only to talk about residential care. Residential care is expensive. It's the last resort for almost every consumer. It makes the carer feel guilty. The person doesn't want to go there, by and large. So if you're short of resources, which you may well be, I would really encourage you in terms of priorities to look at lower cost things that will help the family carer, to look at respite care in particular, which I'm a great believer in, to help the family carer. And don't just make the mistake that we did in Australia, which was to build far too many residential care places, and then 30 years later, wonder why we did it and start building up community care services, which is really what consumers want. So let me move to the second question. What has been learned in Europe in implementing plans and what has been achieved? Florence is going to talk first on this. I hope I haven't got your biography as well. Maybe I'll let you introduce yourself. I won't get it wrong this time.
No.
Have I got it right? It was Jean that got it wrong anyway. Florence is General Inspector of Finance since 2008, has been in charge of the French Alzheimer's Plan and Vice Chair of the Foundation for Scientific Coordination of the Alzheimer Plan. Prior to this, she was General Secretary of the French Insurance Supervisory Authority. She obtained a Master's of Science at the École Politique de Paris, a Master in Economics and Finance at the Institut d'études politiques de Paris, and a degree from the French Institute of Actuaries. Since 2008, she's been a Distinguished Fellow of the IAIS and a member of the Board of Finance. Over to you, Florence.
Thank you. Maybe to elaborate on what my colleague has just said, by the way, I'm not responsible for the French strategy. I'm not responsible for the direct implementation. I'm responsible of the assessment on an ongoing basis of the implementation of this strategy. And I thought it was very interesting what you said about the staff in government who is in charge of the strategy, and you say you need a continuity with the persons in order to make sure that they keep involved in their own strategy. Then this is not at all the case in France. I just try to remember the number of ministries and state secretaries that I saw from the beginning of our strategy, which was only 3.5 years ago. That amounts at 9 ministries and 4 different state secretaries. So I am the continuity, but I think it's just impossible, at least in our country, to have this continuity that would be guaranteed at the level of the ministries. But thanks God, I mean, the continuity, I would say, is first the continuity of the involvement of our president. You know that one thing is very special with our strategy is that it is absolutely top-down. It came from our president. It was part of his program as a candidate to the presidential election, so it came from the top, so it's top-down. I think this is a huge difference with most of your countries. But nevertheless, I think that even with this very high-level involvement, you need a team or a person who is in charge of the strategy on a continuous basis, and that is absolutely key. If I had only 30 seconds to answer your question, I think I would say that the lessons that I draw from the implementation of the strategy would be first, humility, and second, optimism. And let me show you that what is feasible in 3.5 years time. And I think I met most of you for the first time in Oslo 3 years ago. And can you remember where we were at this time? I think there was nearly no European involvement. There was very little international involvement. And definitely I can tell you that there has been a real change over the past 3 years. Regarding our strategy, we had 3 high-level objectives. The first one being to know the disease. I can understand when you talk about medico-social research, for example, but let us not forget fundamental research. Once again, I'm surprised by the fact that we know so little about this disease. Of course, I attended the ICAD meeting in Paris in July. We make progress, but we still do not know enough on this disease. So let us not forget that we must continue to fund research and to put our resources together. And I think it's a very, very positive example to have this joint programming in European initiative on dementia. We have to continue to fund research in the world in order to find, hopefully in the next years, a treatment for this disease. So we need to continue. We also need to invest in epidemiological programs. With my public policy hat, it's very important to know how many people have dementia in France in order to format my solutions. And today, I'm just unable to tell you how many people with dementia we have in our country. We know that it's at least 550,000 persons, but others will tell you that we might have maybe 1 million people. And with once again, with a public policy hat on my head, this is absolutely key, because this will draw the number, for example, of daycare centers, the number of memory clinics that we are supposed to design on the territory. So that was the objective number one. And I would tend to say that we have, after 3.5 years out of 5 years, because our strategy is a 5 years strategy, we have met most of our objectives regarding research, and in particular, there might be some scientists in the room, and I hope that they would acknowledge my assessment, which is the following: that within 3.5 years, France is back in the leading countries for the research on dementia, which was not the case maybe or not so much in 2007. So if you put energy and money, and not so much money, we have devoted 80 million euros to fund research programs in France. This is not so much, but with that money on the table, we are back, I would say, in the countries that really count on dementia. Second objective, which is at the same level as the first one, a very important objective, costs nothing or nearly nothing for public money, so every country can do that. It is to make dementia a societal topic and to respect the will of the person. And this is absolutely key. That was our second objective. And once again, after 3.5 years out of 5, we had met the objective, and we have even gone beyond the initial objective. Just some example, we conducted some beautiful surveys. Since we know so little about dementia, it is very important always to come back to the real needs of the population. Of course, the needs of the persons with dementia, the needs of the carers, but the needs also of general population. Let us not forget general population. And you know what general population says when they answer our survey? They say that they want to have access to their diagnosis if they have symptoms, and they say so with a percentage of 91%. So the general population wants to have access to their diagnosis if they have symptoms. This is very important. And you always have to come back to these surveys and to the answers of the citizens in order to match your strategy. In other words, I think any dementia strategy needs to be some sort of moving target, because we know little, but of course every day we improve our knowledge of dementia, whether in our own country but also abroad, and we have to take into account any news on dementia just because we know so little. So keep flexible. At the beginning, I think we had a very beautiful product. Our strategy is perfect. It's global. It has a lot of qualities, but let us not forget that we need to be able to adapt to any news available in the world. We have created a National Center for Ethics in Dementia, which keeps organizing meetings locally, meetings nationally. We had a beautiful summer course in Aix-en-Provence in the early days of September. So it's absolutely obvious that dementia has become a societal topic and not a health topic in France, and I think this is absolutely key for everyone, including, of course, families and persons with dementia. But we have met this goal not only at the national level, but also at the European level, and I won't say much about that, but I would like to thank Tony for the enormous support that we had in 2008 coming from the Commission after our conference in Paris. So now we have two beautiful European actions. I know that you're going to talk about ALCOVE, so I don't say anything about it, but yet this is the reason why we went beyond the initial objective. ALCOVE was not in our initial strategy, and we went even beyond the European circle, because now the WHO in Geneva has decided to tackle and to put dementia on their agenda. The third objective was to improve the quality of life of patients and carers in their day-to-day life. And there we have met some objectives, but not all of them. So the lesson is to change the life of patients and carers. That is maybe what takes a lot of time. We met our objective of granting access to diagnosis. In France, we have a beautiful network of memory clinics, but I'm not satisfied with that. And I said so to the president in February 2010. And you know why I'm not satisfied? Because you can have access to the diagnosis everywhere, but obviously a lot of patients don't go there, so they don't have access. So you have the network on the one hand, but people do not have access to it. And the reason for that is that the GPs in France won't send the potential patients towards the memory clinics, because in our country, the GPs do not post the diagnosis by themselves. Then we adjusted our strategy. That's the reason why I said it's a moving target, and you learn how to walk by walking every day. So, and I'm very happy to say here today that the Social Security has negotiated all through the summer with the unions, the doctors' unions, and that we're going to put in place an annual home visit of the GP, which will be reimbursed, of course, for the patient and the carer. And I think that is absolutely key to bring the GP back in this process of dealing with the people with dementia. Once again, this solution, this this annual visit at home, was not part of the initial strategy, but we had to adapt, taking into account of the fact that having a beautiful network of memory clinics was not sufficient to grant access to diagnosis. So that was for diagnosis, but once you have post the diagnosis, then you have to take care of the persons. And we had a real difficulty in France. Maybe it's a French particularity, but we are very eager to create a proliferation of systems, and then we juxtapose all the systems. So the paradox is that we have a lot of systems, a lot of services who never talk one to the other. The result of which is that there is no chance that the person with dementia has access to the adequate service at the right time. And that is the reason why we imagined the Maya. The Maya is just an integrated network that makes all these people work together on a local basis, and that will drive the person to the adequate resource at the point of time where they express a need for some service. And so we know now, we have experienced these networks for 2 years now. We know that this is absolutely key for the quality of life, and not only of people with dementia, but more generally for all elderly, disabled persons. Very unfortunately, it takes a lot of time to implement the Maya. So we won't reach the objective of having Mayas all over the territory by the end of this strategy, by the end of 2012, but we will meet the objective by the end of 2014. And then we have a series of solutions, specific solutions, but I will shorten and we can come back on that, in order to secure people at home. And maybe to come back to your comment, you're absolutely true when you ask families and even patients where they want to live, even when they have dementia, the answer, and by very far, is I want to live at home. It's the answer of carers, it's the answer of persons with dementia also. But that's one thing to say I want to stay at home. It's another thing to make it possible. And to make it possible, we have imagined some respite solutions which are maybe more friendly than the basic daycare centers, because we also, in France, we have some problems with the quality of a number of our daycare centers. I think we all have to face this reality. So we imagine some larger sets of services available, which we call platforms. And we also have developed a solution that comes from, comes from a Dutch publication, which has been confirmed by a UK publication, and we call it occupational therapy. And this enables people with dementia staying at home to recover some capacity for some months. So I think this is very positive. It's fully funded by our strategy. We have also, but I mentioned that, specific solutions for nursing homes and on specific units also in hospitals. But for all these very practical solutions, we won't achieve all the objectives by the end of 2012, but somewhere between 2013 and 2014. So as a conclusion, I would say that the lesson of this implementation is that first, implementation is slow. Sometimes it's slow for good reasons, because, I imposed to the pilots to liaise constantly with all the stakeholders, and this takes a lot of time, especially at the beginning, but then when you implement the solution, then it can also save you some difficulties. Second lessons, it takes time to convince the local actors. That came as a surprise to me, because when you have all these expert groups, French, European, totally international experts who have imagined beautiful solutions, then you knock at the door of the hospital or of the daycare center or of the nursing home, and they don't want of your beautiful solution. Then it takes another year or another 2 years to sell your solution, even when you have all the experiments that tend to show that this solution is adequate. So this is also maybe a reason why it takes a lot of time. And last but not least, maybe last message, what is key for the implementation is the availability of trained staff, and training the professionals to the specificity of dementia takes a lot of time. And this is also maybe a point to take into account when developing your own dementia strategies.
The European Union has limited powers in the area of health. In fact, this article in the treaty says that the mission of the Union is to preserve health of Europeans and to combat any danger, etc., in the respect of the national competences of the member states, which means, in practical terms, that the member states of the European Union are fully competent in the organization of the different national health systems, and the powers of the European Commission are powers of coordination or powers of action only on the basis of a constant dialogue with the member states about what we can do in a European perspective. This is a situation that has disadvantages. If you imagine the agricultural policy, the environmental policy, the external trade policy, in which the Commission is practically fully competent, we can say, in order to adopt different policies, this is not at all the case of health. But this situation has advantages and disadvantages. One obvious disadvantage is that we cannot, as European Commission, be claimed for not doing certain things for the simple reason that we cannot. And that we can, on the other side, say is that when we propose in the European public health policy a certain number of priorities, not always these priorities are accepted by the member states. I should say that in terms of diseases, the Council of Ministers has adopted as priority areas for action in terms of diseases certain limited number: cancer, rare diseases, infectious diseases, mental health, and occupational diseases, which not belongs to our directorate. Not Alzheimer. That should be clear from the beginning. Not because the Commission don't want, but because for the moment, and this is the situation that we should accept, you should accept, there is no consensus between the 27 to declare really beyond the words that Alzheimer and dementias are a priority in the action of the European Union. Okay, what happens is, for instance, comparing with other sectors, is in the case of rare diseases, we adopted a Council recommendation, etc., in which all the member states are obliged to have a national plan on rare diseases before end December 2013. Same thing happens with cancer. All the member states are obliged to have a cancer national plan before end of 2013. We have a European working group on national cancer plans. We have Europlan, which is a European plan co-financed by the member states in the European Union to help the member states to prepare the national plans on rare diseases. But we don't have any obligation, Europe don't have any obligation, member states don't have any obligation to have an Alzheimer national plan before any particular date. That's a difference. That means that it's very good that in all the member states there are steps, actions, strategies in place, but there is no, at European level, at the difference with other diseases, an obligation to have these national plans. Okay, that means that if we don't have national plans at European level, we don't have either a European plan. At the difference of my colleague of Scotland, I cannot show you this is the European plan and this is what we will do in the coming times. Unfortunately, I cannot. I don't have this European national plan to show you. Then what happens is that we should, in the case of Alzheimer, act, as I said, with the complicity, the impulse of the member states or the European Parliament. We had an enormous chance in 2008. It was the French presidency. The French president of the Council was extremely engaged in launching European actions in the field of Alzheimer and dementias. That was a benediction, a bless, a real. And after this, in 2008, we had the chance at the beginning of 2011, this year, that the European Parliament has adopted a resolution confirming this and asking the Commission and the different member states to start different actions in the field of Alzheimer and dementias. Without this impulse from the French presidency in 2008 and the European Parliament in 2011, it will be very difficult for us to do actions because we don't have legal basis, because we don't have really a political framework for doing this. What we have done then is to be creative using the not too much instruments that we have. When the French presidency adopted conclusions in 2008, immediately, we were prepared for this, we adopted a Commission communication in 2009 in which we decided to do certain number of actions that we have implemented. That's my pleasure to tell you. Practically all. The most important one from the side of the public health, it was the launching of the joint action ALCOV. ALCOV is an acronym for Alzheimer Cooperative Valuation in Europe, which permitted to have at this moment 19 member states, I think, together working for certain precise objectives in certain fields. Prevalence. Somebody in the previous session asked how many people really suffer from dementia in Europe. You cannot do this only at national level. It's impossible. You should do this at international level, in a cooperative level, in an international dimension. Eurocode, that was a project supported by the Commission and launched and carried out by Alzheimer Europe, has done an exceptional work on this, but we need to refine, we need to complement, we need to do better. And this is one of the missions of ALCOV. Of course, ALCOV is also working in early diagnosis, in the current services, in ethics and dignity, something absolutely important. It's not acceptable that a person suffering from Alzheimer has completely different rights according to the state of residence. If you live in one country, you have one type of rights. If you live in another country, you have another type of rights. But we are, it is supposed, in a political union, in a political space, with free circulation of persons, with free circulation of goods, but unfortunately not with free circulation of people suffering from Alzheimer. That's something that really we need to resolve. ALCOV is a big contribution to do this, and I'm very pleased to say that really they are working very, very well, and I hope that this project could be continued in the future. But that was not the only point. We had this need in some aspects of the public health action, but also in the field of research. There is an enormous amount of money that is spent every year in Europe in research for Alzheimer. Approximately only 50% is really spent in projects that could be considered as cooperative at European level. 85% is projects at national level, duplicating, triplicating, quadruplicating sometimes things that are done in another member states. That was the reason for which the Commission decided to propose, and that was also endorsed by the French presidency, and with their support, it was possible to create what is called the Joint Programming Neurodegenerative Disease Research, the GPND, which is a very relevant project coordinating at this moment the action of 21 countries of the European Union, 20 of the European Union, one outside the European Union, in order to coordinate really actions in the field of research. And it was necessary a third big pillar. It was to coordinate, at least when possible, the research in the side of medication, in the side of drugs. That was the reason for which a project called Pharmacog, that was presented, I think, here yesterday, was created and funded by the European Union with the cooperation of the European Federation of Pharmaceutical Industries in order to put together as much as possible, because as you know very well, working with pharmaceutical companies is very difficult that they exchange really all, but at least they exchange the maximum possible in terms of really avoiding a waste of resources and waste of in the research. And something very important that we pretend always in the Commission, that they should share not only success. Sometimes the most important thing is to share the failures. Because if you share really the things that you have not really well done, is a way that really you will not repeat the same thing and again the same failure some months or some years after. And sometimes the most difficult thing is really to share the failures and not to share the success. But we are trying to do all these things. These big three pillars, the GPND, ALCOV, Pharmacog, are complemented with other actions derived from this Commission communication on a European action on Alzheimer. One that we want to do next year, it will be in order to help our colleagues on ALCOV, the launch of the European Health Examination Survey that will include a module on cognitive decline that will permit for the first time at European level to have better data, because a health examination survey is not a survey by interview, as the name indicates, it's a survey by examination, and 200,000 Europeans will be examined in a similar way for their cognitive decline, and that will provide very valuable data in terms of prevalence and predictive models for Alzheimer in the future. This is something that we will launch next year, 2012. That's what we have done without having the paper. If we will have a paper saying European Dementia Plan, European Dementia Strategy, probably we can be more efficient. But we try to do the things with the instruments that we have. And finally, something that is very important for every one of you. Last 27th June, the President of the Commission, Mr. Barroso, presented in Brussels what is called the multi-financial framework, which is the budget of the European Union for the next period of years. You know that in the Commission or in the European Union, we are not working with yearly budgets. At the difference of the Member States, we work in budgets that are normally for a long period. Now it starts the discussion for the budget 2014-2019. And in this budget 2014-2019, it will be the third health program, the FP8 that now receives a more romantic name, Horizon 2020, and the structural funds. Three big financial packages that affects directly you, that affects directly the interest of the Alzheimer communities in every one of the Member States. Of course, I don't want to do the roadmap for Alzheimer Europe, because I suppose that Heike and Jan will be not very happy if I do this. But in any case, I think that you have, as Alzheimer Europe, a relevant role as lobby in really influencing that these new financial perspectives that should be approved by the Member States and by the European Parliament later should respond as much as better to the interest of the Alzheimer community, devoting more resources in the future health program for Alzheimer, in the future Horizon 2020 for Alzheimer, and of course the structural funds, which permits really to do actions to support infrastructures for serving the people suffering Alzheimer. Then, I think that Florence said that we can be very happy. If I examine myself the situation of the European Union in relation to Alzheimer in 2007, which was the complete desert, and I examine the situation today, I could say that really some real concrete things have been done. And I add another concrete thing that we have done, which is the support, the direct support to Alzheimer Europe, using an instrument in the health program called operational grant, for which I think you have received for third consecutive year financial support from the Commission. And my congratulations for this. And I think that's a series of actions that really permits and needs to be enlarged in the future, because really the most successful action for preventing, for treating, for caring, and one day probably for doing something definitive for the people suffering from Alzheimer is not only the local, the regional, or the national action, it's also the European and the world action. Thank you.
Well, we've got time for a couple of questions, so either related to the first question or the second question. Yours to ask what you wish.
Thank you. Peter Ashley again. Addressing my question to the representative from the Commission, I'm a little confused as to what you say. You say you've got a policy for mental health, which is approved, and yet you say you've not got a policy for Alzheimer's. My understanding of mental health is that it comprises two parts, functional mental health and organic mental health. Organic mental health is neurodegenerative disease, and neurodegenerative disease is dementia or motor neuron disease or certain other diseases. So why is it that this isn't embraced in the mental health policy?
What is called the European Pact for Mental Health and Well-being was adopted during the Slovenian presidency in 2006, if my memory is good. It has, as you say, different work packages or different objectives, focusing on health for adults, health for young people, mental health for older people. Of course, in certain moments, we have used this European Pact for Mental Health, which not refers explicitly to Alzheimer, as a way for doing certain type of actions. But this topic was discussed between the member states in the Council in 2008, at the moment of the initiative of the French presidency. And I will say 26 from the 27 rejected to use the European Pact of Mental Health as an instrument for the policy on Alzheimer. The only one that supported to use the European Pact for Mental Health, if you are interested, was Finland. The rest were absolutely against. Then this is, as I said, we as Commission, we should follow what the Council of Ministers in this type of topics decide. We cannot improvise policies in the field of health without the agreement or the consensus with the Member States. Then the position of the Member States is unanimous, I will say, 26 from 27, of course.
Thank you. Any more questions, or are you all exhausted at the end of 2 days? Looks like exhaustion has set in. Well, perhaps I could just thank the 4 speakers for making my job so easy. I enjoyed that because we're on the other side of the world and learning what people are doing is very hard from Australia. I guess the things that strike me about the conference, listening to it over the 2 days, are the importance of primary care, and certainly in Australia we've neglected that. And as Subi said on the first day, if you don't know the problem and you're not diagnosing, you're not going to do very much for your clients. So I think that has to be a priority, and it's certainly not one that's been addressed in my country. Secondly, I think the sustainability thing is important. We were the first country in the world, I think, to have dementia as a priority at the national level. We're the first country to renege on that because the government in the last budget decided that they would go on providing the money but not have dementia as a focus. So we're about to march on Parliament House next Wednesday, listen for the noise, to let politicians know that we're not at all amused. And I take Jeff's point about partnership. We believe in partnership with government, but there comes a time when you actually have to tell your story. We've had some mention of antipsychotics. I'm glad that Florence raised that issue. It's one that I think Alzheimer's organisations really don't do enough about. And I include Australia in that, and I hope we do better. And lastly, on the research story, my sort of guess around the world is that Alzheimer's probably funded 1/7 to 1/10 of cancer, and that really isn't good enough. In Australia, dementia gets a miserable 20 million, cancer 140 million. And if you look at prevalence, if you look at disability burden, if you look at cost, then really, as Subi said on day one, again, research for dementia should be a priority, and it should be a priority without sacrificing services. It should be money that should be there from government and from the community. And lastly, I think I just pick up Jeff's focus on social issues, the post-diagnosis issues, making sure people have key workers to help them through the system, get the support, plan their care, plan their legal, plan their finances. It's so important, and it's something that I think we all need to do a lot better if we're going to take the trauma out of the journey of dementia. So please join me in thanking my colleagues, thanking the Polish Association for allowing us to have this final session, and thanks to John for inviting us all. So thank you very much.